Now the house is open for discussion. Any questions from the audience?
Yeah, I have a question for Dr. Chakravarti. I really enjoyed your talk. Large data. If my understanding was correct, you said the second wave had less survivors from ECMO. This has been contrary to our experience. We had almost 50% survival. I think perhaps Murali can comment on it in the second wave as compared to the first. So overall, if you look at our COVID survivors following ECMO, roughly comes to around 30-35%, including those who had a transplanted lung. But, and this is something we are trying to answer as well, can you give me some kind of answer on, can you predict who is likely to recover? That's the hardest. And then the second thing, of course, is a significant number of patients would have, more would have recovered but for the complications, you know. The lung is improved beautifully, but they have a bleed in the brain and they die. Or they have a retroperitoneal bleed. So complications obviously is a dampener. But do you have any sense of who's likely to recover in your experience?
This is quite a gut feeling actually. Why our second wave is went down? The explanation is we received all the, because in the second wave, in every nooks and corners, there are HFNC, these bypass are available. So none of the patients actually came to us for ventilation or for the before 4th week, 3rd week, before that. And most of the patients, I can show these things, they received 3 doses of tocilizumab, lot of other came to all these things. So these things has reduced, there is no problem with their lung. We lost them because of Elizabeth Kingia, because of bad Acinetobacter, the pus coming out. So in the first wave, people were frightened to put them on ventilator, and when the saturation was coming down, they are sending to the higher center more frequently and early. So we got patients early, and without those tocilizumab was not that popular at that point of time. So we get them early. So we could achieve a 40, almost it was 44%. It was a kind of golden time where I can see the 11 of the doctors who got admitted, 6 went home, and 44% was our outcome of the first wave. In the second wave, we just slashed down to almost 28. Few people are coming out, so the number will go up. We have lost a lot of them. So probably this is the thing, and I am sure if we put them early, the people we have put them early, they came out early, they come out without any problem. And the people received more than 2 doses of tocilizumab, none of them survived on ECMO. None of them, from our institute, we could not control sepsis at that point of time. So probably this is my gut feeling that the early thing probably is giving good results. We are not a robust transplant center, so we could not make them probable list, but we put them on the list. 3 people we put them on the list. One we did on day 104. Unfortunately, he didn't survive because of bleeding. And the 2 went down because of one, the patient went down because of this right heart failure, and we could not get that heart-lung transplant done. But probably with transplant, few patients could have been saved in our thing also. But we lost in the second wave because of the late referrals and the number of immunosuppressants, the number of ventilated days in means of BiPAP, HFNO, and all these things. So people started intubating them on the week, 4th week, 5th week. So that was the probably our debacle, cause of debacle. We don't know, might be this thing.
Murali, would you like to add something to that?
What at least I have seen or I prefer is in that acute 20 days of COVID time, though everyone has the concern to go into the COVID ICU, I feel that's the best time because that's where your chances to pull out a patient is best. Again, to put it forward as a question to you, do you think the same, that doing it in the first 20 days makes a difference rather than putting them beyond that? Usually more than 25 days, I counsel them that your chances are relatively less than who are the ones less than 20 days. I think Prabhat, you like to add?
first wave what we saw, our second wave results are better because we get a younger patient. First wave we got more elderly gentlemen, 60, 65. So what we got, first wave results are not good that much. Second wave our results are much better. What we did. When we got a much younger. Yeah, absolutely.
No, second wave we fought.
Second wave is better. Because we got a more younger patient and they are ready for ECMO. First wave we had to counsel them for a longer time because ECMO awareness was not there. I personally feel most of the patients are not, why ECMO, why you want to put it and all those things.
So there was a difference. In first wave, the ECMO references were less, and probably the survival was better because of, they used to come a little earlier. And second wave, what we faced, probably this is the difference between the transplant center and non-transplant center probably. We faced that the patient, as Arpan said, we get the patient after 4 weeks of 100% HFNO and NIV and that. Yeah, there might be a history of only ventilation for 1 day. So that is not an actual ventilation. In fact, they be lingering around for almost 4 weeks and then they come. So, but the awareness was much better. And that's the reason the reference was
Much better.
Reference was more.
second phase,
The number
infection
of
was much
cases
better.
who were going for ECMO was much more in second phase as compared to the first phase. But probably because, in fact, we kept that if anybody is receiving more than two, in fact, second dose of tocilizumab, we used to refuse them. Because then we found that they are not doing well. But probably then after a few weeks, they usually go to a transplant centers and probably that's the reason might be a better, after transplantation, we might have got a better results of something of that sort.
Arpan, what about your digit problems? Have you seen?
Yeah. A lot of digit problems, the peripheral digit problem we have seen probably in the second wave mostly. I don't know why. This is probably the peripheral DIC kind of thing which is happening.
Many patients have lost digits.
Yeah.
But we don't know how to treat it and all.
But we have not proactively amputated those digits because
It is autoimpedance.
and outcome wise, if I see my age duration, what you were telling that youngers did well, my thing the middle aged did well, 40 to 60.
Yeah.
40 to 60 did well.
They did well.
Younger had more chance of cytokine storm and all this.
Yes.
And probably few people have taken steroid at home, kept on taking oxygen at home, then they got admitted in the hospital, then they started the time. And at least we got all patients for 4th week. Before 4th week, we didn't get any patient for this is the second wave.
And just what was the incidence of hemothorax in our patients? I have at least 5 patients with a massive hemothorax. We required an exploration and
Pneumothorax or
Hemo,
not
hemo.
pneumothorax.
Pneumothorax, probably, I don't know.
No, it is
I
not
got like-
pneumothorax. Question is hemothorax, I think. No, putting a
Hemo,
chest
hemo.
tube. Putting a chest tube. How?
That was earlier discussed in our group.
During putting chest tube.
No, it is
No,
telling
before.
spontaneous kind of.
Spontaneous.
We didn't get it, sir. We didn't get it. But pneumothorax, these Ehrlich syndromes are rampant.
No, that was rampant. But even
syndromes
we
are
have seen
rampant.
quite a few spontaneous hemothorax.
And few pneumothorax we didn't put drain, sir.
Hemothorax, yes.
Hemo.
Hemo. After chest tube, yes.
Spontaneous we have not seen. After chest tube, many of them are big.
Yes.
It's a disaster. And sometimes, I don't know whether it was scientific or not, few pneumothorax I didn't put drain on ECMO.
Not
Not
to put
put a
drain.
drain because it is not going to give any, it was not helping at all.
Our pulmonologist done a spigot, sir. They identify the place and put a spigot. In fact, we disconnected
Ventilator.
Yes.
We did it. And the idea, but one I was asking you all, what was the idea of putting awake ECMO? Because it proved disastrous with me.
No, in fact, we have better results. In fact, we have better results.
So
We
that's
were
the-
quite happy with an awake ECMO.
Extubated them as much.
No, not extubate. I'm
Okay.
telling you, putting them awake. Not extubating means when they are out of that acute ARDS setting. That is fine.
No,
I'm
awake
telling you,
was
if you
better
put
actually.
awake and all
But
this.
for that you need a early referral.
Yes.
And they
For
should
that-
accept for it.
I have
That
put
is your
them
60, 60,
fully
70,
awake.
80, 80, 90, they're already gone.
Saturation is fine, good flow, but slowly they went down that ARDS of that low sepsis and I have to intubate. So I am discouraging people not to put these things. I don't know, the data has not came out.
No,
Yeah.
again,
See, it's not that we
no,
started awake
I don't
ECMO
think
to
so.
start
I
with.
think
No, I'm telling
We
you about
put
starting
we
awake.
no started awake. We started tried in 2 patients. When both the patients, we eventually need to put them on
When you're
ventilator.
putting
That's why
ILDs
the
pre-lung
people
transplant is
didn't
perfect
give
thing.
consent for ventilation.
But something
Yes.
They
as
were
aggressive
ready
as
for
ECMO for a
in
COVID,
two
before that you are
instances,
supposed to
we
intubate,
put them
go
on
on
ECMO,
P,
but
prone them,
eventually we have to
and
intubate
see
because
that.
of
But
this
whether you
ongoing
bypass all the
But
steps
here's
and
one good point actually.
for an awake ECMO, you can do in 2 situations, like what Dr. Prabhat explained. If you are doing for an ILD for a pre-transplant, that I think is very good. Very good in the sense that you avoid that infections are less. But if you are doing for a COVID, you are taking off a lot of possible helpful measures like your intubation, manipulating PEEP, putting them on prone. You think, is it worthwhile bypassing so many steps and just
No,
directly
no.
jumping
See,
on
what
ECMO?
we have done is initially we ventilated them for 4-5 days, and then we extubated them.
That
No,
is
no.
fine, sir.
What
That-
Arpan
that-
was saying
that
is
not
To
do
start
the
with
job.
awake ECMO,
So starting with
yeah,
the awake
no.
ECMO, because lot
That
of
we
people-
tried in 2 cases because both of them were not willing for
Ideal
ECMO.
referral was
Ventilator.
patient is on 100% of HFNO,
Give chance.
maintaining a saturation of 75, he is awake,
correct.
talking to relatives.
Request
So
to
everybody was asking,
If you are
don't
able to
put him on ventilator,
Yeah, I'll
do
do
something
intubate
without
the
putting on
crash.
Yeah,
ventilator.
not to do
So that didn't go well.
No. We tried in 2, but then eventually we required to intubate both of them. Probably in acute phase when the acute ARDS is still going on, that may not be a good idea. Once the thing settles down, the acute phase settles down, the surge reaction settles down, probably then you might think of extubating them or taking them off ventilator.
Then were the bleeding complications more per se because of COVID, or it is because we had long runs?
No, bleeding complication was not more with
One
us.
more thing I can tell you, from heparin, if you try to bypass, if you many patients, I think Sir Ernest presented also, that time post-op bleeding cancer came down for us. His platelet is to be around 80.
Better.
Post-op, I have not much of idea, but
Not post-op, post-ECMO.
bleeding complications this time is not with not that digit problems are there and platelet issues were there. We ran lot of without heparin ECMO for a longer time because 90 days ECMO ran for at least 30 days ran without ECMO.
Without ECMO.
Because we don't come down on the flows, we just manipulate
gas
with this sweep around this. So that we did, but bleeding complications fortunately it didn't.
After bypass, this bleeding complication came down much better way.
Okay. In fact, we tried bivalent, but it was availability was a big issue,
Even now
so we
availability
couldn't
is-
get it much.
Even now?
Yeah.
No,
You get it
some of
easily?
them are- Some
Yeah.
of them are available in India.
No, but we didn't get it. We tried a lot, but probably in that phase, during that phase, we didn't get the bivalent.
Sir, do you consider CT score before putting on ECMO? Do you consider CT scoring?
For before
In
putting that
predicting
patient-
ECMO
so this
and-
is another fallacy. People with 23 score didn't go on ECMO, they were just without oxygen roaming around, and people with 12 score, they land up the next day they got intubated and all this. So that is not a very corroborative finding at all.
Even
That is
I
wrong.
agree.
What else can be?
And that rapidly progress. You don't know because when the guy is getting admitted, the CT score is 9.
Yeah.
And the next day you see this saturation 65. If you have no time to get that CT done, it would have been gone up like this.
So you consider
CT
gases
score,
first.
CT score we have not considered. Obviously, one CT was done for every, but it is the result is not very corroborative. Recovery CT, again the recovery CT. I think this recovery CT is also very eye opener because when the patients are getting going home, at that point of CT may not be very good at that point of, but they are maintaining good oxygenation at that point of time. If the GGO is persisting, after 6 months that is completely reversible. That is happening. I don't know. Soumitra also probably add some.
Yeah, our follow-up of those patients who have recovered post-COVID, post-ECMO, now some are about 5 to 6 months, their lung is still showing the fibrosis, the interstitial fibrosis, and along with that the honeycombing and some traction bronchiectasis, just like an IPF. But they are maintaining good saturation while sitting at home or walking. I am talking of those who are almost, we have considered them for transplant, but somehow they have
Yes,
come back
yes, yes.
and gone back home. So they are still having a desaturation if they walk say more than half a kilometer or 1 kilometer. And the cough, those things are persisting. I really don't know how long will this now with this traction bronchiectasis and with honeycombing, whether they will at all improve fully or not. I doubt that.
So that's the thing. If you measure this DLCO and FENO, these are getting haywire, these drugs, but they are doing well. They can go to their office and they are doing. Let them give some time, because we are giving that first.
From all of you who has large experience in ECMO, particularly COVID, who are the patient you think should be prone, COVID patient, and how do you decide that this patient should go for proning? Because see, proning and ECMO is a lot of problem. What we have faced a dislodging cannula also. So who are the patients who should go for proning?
Sir, my criteria, I don't know what others are using. My criteria for pruning after ECMO is, if I am not able to get up, even on ECMO, the saturation is more than 85%. Pruning,
Okay.
I have categorized for hypoxia on VV ECMO, the A should be pruning, because at that point of time, when the 20-25 patients on ECMO or few more in other ITU, the pruning has become a resource intensive factor. So at that point of time, my criteria of pruning was, even after ECMO, if the saturation has not improved more than 85%, so I prone them. So I take it as a measure of hypoxia on VV ECMO at that point of time.
So if I think that, just if a patient is not improving and you have done a lung rest setting, so first you go to actually increasing the lung support,
No,
or
sir,
you
I
decide
didn't
for
do
proning?
that. I didn't do that because I have burned my fingers by increasing the lung settings. I just kept PEEP at 6
Okay.
and the thing is 16. Not allowed anything more than 22 to 24, because obviously they will land up in pneumothorax or this surgical emphysema and all these things.
Okay.
So don't believe on your ventilator. If you have put him on ECMO and not maintaining saturation, prone that.
Prone.
That is my idea.
I think just answer to your question, what we do is, once we put them on ECMO, we'll do the CT, because before that you can't do.
Not possible.
And in the CT, if you see more consolidation in the posterior
Recruitability,
zone,
yeah.
then we'll definitely put them
That
on
is
ECMO.
another.
That could be another.
That's
See,
right.
what we
Thank you.
are used, in fact, we started proning patient on ECMO mostly during the COVID time. Before that, we were not used
We
to do
were
that
not,
much.
yeah.
What visual is one of the factors definitely is not maintain saturation. But more than that, what I used to do is we used to see how the lungs are. If both the lungs are wide, if the volume is less than 100 ml, then in that case we used to, irrespective of whether, even if we maintain saturation of 3.5 or 4 liters of ECMO flow is maintained saturation, we used to prone them. If the lung volumes are low, that means the poor compliance, then we used to prone them. And we give at least 5 cycles of proning, and we used to do it.
I think
But
this-
not only on saturation, but then even compliance. We used to go guided more by
Sometimes it has
compliance.
improved.
Yeah.
I think this proning, repeated bronchoscopy and tracheostomy, these three has given good outcome on ECMO. These three things.
So by default,
If the
all of them
volumes
we
are
prone.
good,
All of
then
them,
we
all
try
of
to
them.
get them
Prone all
awake
of them, all
in
of them.
3-4 days and get them.
Unless you have a reason not to on that day. He's hemodynamically unstable on that day, or
No,
you
that's-
need some other issue to sort out. By default, we prone. Almost everyone we prone.
Yes.
The question is, those patients who are coming from the ECMO, they already have been prone for 5-6 times, and they have not shown any signs of improvement on proning. So I do not know what we are going to achieve by putting the patient who is a very low lung setting and you have proned them.
No,
So what is the benefit?
No, that's true. Not everyone will benefit out of it.
Yes.
But who benefits will really benefit out of it. And second thing is the conventional way it is practiced, like 3 cycles of proning is what is conventionally practiced in most critical care units. I think that may not be enough. There are patients in whom we prone for 11 days continuously also. So there you see that they do have a benefit.
Okay.
Rather at times even late proning where you do CT at the end of 4th week or 5th week, that still shows you that the posterior segments are involved, like Suresh Rao said. Again, we go for another round of proning. And by default, once proning is off means within a day or two, you are expecting him that he is going to sit in chair. mobilize. They're not in bed supine. Either they are prone or they are sitting in chair.
Okay.
Question is, no, very difficult to recruit because the patient is already very low tidal volume. Usually tidal volume you can say 1 million ml per kg body weight. So if you are going a deliberately recruiting, that is different issue. But 1 ml per kg tidal volume or 100, 200 ml tidal volume, I don't think a posterior lung is going to be recruited. That's the thing. Maybe some mechanism.
What you are telling is right.
Yeah.
There are definite prone responders and there are non-prone
Non-responders.
Yeah.
We have seen lot of non-prone responders also. That's why I just limited thing on if hypoxic on windy ECMO,
Okay.
then I go. I don't walk in the setting because invariably I know this patient is going to burst thing and your thing is done.
Thank you.
One last point of discussion, we're running out of time, is this question of timing of lung transplant on ECMO. The very first one we did, he was on ECMO for 30 odd days. And clearly, the sooner you do, the better are the outcomes. They're not so deconditioned. But in the second wave, we have seen recovery at 75, 76 days on ECMO. So you'll wait, hoping it'll recover, and if they don't, the lung transplant becomes more problematic. The last lady, that Vandana, she was on ECMO for 3 months, had a cerebral bleed, recovered, several septic episodes, then had a transplant, and she eventually went home. But that is so do you have any clear-cut guidelines? I'm not able to make up my mind.
What we do after 1 month, 6 weeks, means for 6 weeks, we don't try for any ECMO, transplant things. After 6 weeks, I showed one slide, we get the CT scan done after 21 days and 42 days. If the CT scan and his lungs is improving, then if he's not improving, with counsel the patient relatives for transplant and all those things. So by the time we go, it's after 2 months usually nowadays. First wave, sir, we have done transplant after 28 days, 24 days.
That's too soon, I think.
Yes, sir. To very honest, it's too soon. Because we have seen after 60 days, but kids are all getting fine and going
But
home.
it still doesn't answer our question. We are not able to
Sir,
have a more granular data on who's going to recover.
Sir, that's the thing. So usually nowadays what we have done after 42 days, 6 weeks, we do a CT scan. If nothing is improving, talk to the relatives. That patient needs, then they do all the tests and all those things, pre-lung pump.
Murali, do you have a sense of who's likely to recover?
So very difficult to say, sir. Probably CT is the only one that will guide us. But
it's, sir, sometimes CT goes there and it's stuck there only. Yeah.
there are patients in whom you are able to.
One thing I have seen is if the honeycombing, all those things appears, we know that lung is not going to improve. If it is consolidation, you have the chance of lung getting improved and.
Getting every 3 weeks, one CT can tell you.
So that's what I tell you.
We have seen very few patients developing honeycombing in COVID time. Most of the time we do CT, they are just dizzy or a thick consolidation, that's it.
Those fractions, I think, sir, we should now look for the fraction of the disease and those honeycombs. If they are there, extensive, this lung is not good.
Yes.
So I got a consumer case. I have to appear, so that I came down here to get that answer. When should the ECMO lung transplant should be offered? Because he was on day 33 and he still was COVID positive. So and he was septic. I didn't offer any lung transplant possibilities to him. So he just questions from a lawyer's letter. So why didn't give? So I just go through this. Anecdotes literature where Ankit Bharat was the main. He has given a newspaper interview where he has mentioned that 3 months the US is telling, before 3 months of acute therapy, we are not giving lung transplant thing. And probably, sir, I don't know what you are telling also the same now, because you have postponed the thing.
Remember in India,
Yeah.
3 months on ECMO, your family is wiped out for 10 generations.
Yeah, so that's the thing. So probably we can start talking about after 6 weeks. That should be the consensus for this. Yeah. And what is that if he didn't become COVID negative?
No, then you do the biopsy actually. Because the debris will be there always positive.
Viral culture.
Viral culture at all. So you have done it that the RT-PCR is positive and you are going to lung transplant. Did you do that? So probably I'm going to win that case. So let's see. Please.
Sir, if you have initiated an ECMO and the patient is still on ECMO not showing any signs of recovery, and we have counseled for lung transplant but the family is not willing. So how we go about weaning of the ECMO, because if we wean, the patient is not going to survive anyhow. So what are the medical legal issues that we'll face regarding it?
We have a lecture on that. So.
Okay. Thank you.
Okay, now with time.